So as I said, what we're going to do now is really try and apply some of the things that our speakers have spoken about with great eloquence and across, as you can see, a great amount of diversity, and try and embed these in a couple of case studies. Some of them are a bit technical, but hopefully we'll extend the story out. So I've chosen two of them that I think might be most relevant, and thanks to those who participated in the survey, once again, they may or may not be statistically validly presented today, so I apologise for that. So I'd like to get you to imagine John. He is a surgeon, he's recently qualified, he works across both public and private. This is a common model across the country. He's been out a couple of years and already, as we've heard today, he's subspecialising. He's decided that he wants to be really good at what he does and he's going to do mainly elective knee procedures. But as part of his public hospital appointment, they have a thing where you do trauma on call. So if there's major orthopaedic things, major pelvic fractures, compound fractures, spinal injuries, he might have to take care of them. He's also filled out a lot of credentialing paperwork, let's face it, as he went around these 3 different hospitals. He has to do fire training, and now Susan's going to get him to do a senior medical officer performance review, a lot of paperwork. He's sort of wondering whether he should even do this public work because, you know, it's pretty nice in private, as Vincent just explained. So I guess we can talk about a range of issues, but these were the 3 I thought were probably relevant to some of the discussions we've had. Should he be doing that? Is it outside of his current entrustable professional activities? Has he fallen off that curve for trauma on call? Should he have to participate in all those different performance management processes? Can't these guys get it together? And we've heard a little bit already about the third of those. So Ollie, I might ask you the first one. You know, how would you view this in terms of an EPA? Should he still be, has he got an EPA for trauma on call that he's fallen off? Is that even an imaginable thing in the continuing professional development world?
Well, if he does not not meet the standards according to what people think are the standards or his environment, the logical thing would be that he would end up at a level that he needs a little more supervision, I would say, and then people would actually have to more closely monitor him.
Mm-hmm, mm-hmm. Susan, is that even practical? I mean, you've got this guy, you have to count him as a number 1. You can't have 2 surgeons on call, can you? Or you just tell him to stop doing it?
I think it'd be a time for a conversation. And I have to say, in my experience, surgeons are actually quite good at saying when they don't want to do the on-call anymore, when they're feeling that it's not their skill set anymore. Yep. And I think when they get to that point, you need to have that conversation with them. They often still want to contribute to the public sector. They still want to do their knee procedures. They still want to be involved with training and do the bits of research. They're the attractive things about coming to the public sector. So it'll be about working out how we could do that. You know, I mean, really doing trauma on call, you know, he may not ever even come in. If you're at a place like the PA, tertiary centre, lots of fellows, all that sort of stuff. So very, very quickly he would be becoming unskilled in that area. And so I think it's a conversation starter, there's no doubt about it.
Mm-hmm. Okay. And Graham, I know you're not an orthopaedic surgeon, but going back to your comments about sort of technical versus the other aspects of this on-call performance, would he know whether he was good enough? How would anyone know whether he was good enough to do it?
He'll claim not to be good enough. And because he doesn't want to do the on-call, and that's the reality of it. And
That's right.
And you know, in General Surgeons Australia, which is in general surgery, we wrote some principles around emergency general surgery. The same would apply to orthopaedic surgery, and we would regard that that emergency surgery is a continuing core competency. And if you don't demonstrate continuing core competency, I wouldn't be employing him, Susan.
Mm-hmm. And how do you demonstrate that?
Well, he's got to demonstrate it by practice. He has to keep doing it. He's got to come in, not leave it to the fellow.
Yep.
Why? Because I mean, this fellow-led service, that's not right. There's a problem there.
Yep.
Not being identified in the SPMR really, but anyway, there is a problem there.
Yep.
And it shouldn't be arduous because it should be during the day. Those operations should be being done during the day. And he better not be down the private hospital doing the knee procedures at that stage. He better be in the public hospital doing his trauma on call.
Yep. To get to the detail of that, Susan, in his SMPR, would there be a measure that picked up on him not doing as well on these emergency procedures that he did when he was on call?
As part of the multi-source feedback, it would. So you'd capture it in the multi-source feedback from his colleagues and from his junior staff, and probably from the nursing staff in theatre, which would be a key source of MSF for surgeons in particular, about their attendance. So their attendance, their willingness to support and all that sort of stuff. So you'd pick that up quite quickly.
Yeah, and fellows might say something like, nice guy,
Yeah,
can't
never
operate
comes here, yeah.
operate on a fractured femur.
No, that's
Yep.
exactly.
Can I just say that if I was involved at the private hospital he was in, I'd be very concerned about this new graduate. I would be thinking twice before I actually accredited him, to be perfectly honest.
Okay, why is that?
Well, because I don't think that it's healthy for a newly graduated surgeon to limit their scope of practice so significantly, and certainly our best model of fit is for the VMOs, at least at our hospital, to also practice in the public sector. So I think, it's sort of very hard to separate the two out. Perhaps we're in a unique situation because our hospitals are co-located, but we'd be very concerned about that surgeon wanting to only perform knee operations.
So again, we've kind of made allusion to this, that the good guys are in the room. You'd be very concerned, you'd have a conversation, but if he was about to bring in $1 million worth of knee operation money?
Yeah, I think that, and that's certainly the problem that's existed in the past. It is a poison chalice. It will bite you in the backside eventually if you accept, the surgeon who brings in millions of dollars into the hospital for doing 2 or 3 procedures, and there's a cultural problem with it. There's a performance problem. If you accept that, eventually you will suffer for it. And we're certainly of the opinion now that, in the evolving landscape, someone else will come and fill your shoes.
Okay. And I guess just to think about this at a system level, Ollie, so I think we kind of heard glibly from Graham, if people decide I'm not good enough at this and then I don't have to do on-call, do we run the risk of an EPA concept in CPD somehow decimating our workforce for the less popular kind of work?
Yes. But the other thing is why, I mean, there's a whole literature, and there's several people in the room that have contributed to it in Australia about why is it not popular? Because in fact doing trauma on call should be extremely popular. That's why did a guy want to become an orthopaedic surgeon? He has a fracture, he wants to fix it. That's why he's done orthopedics. And
Just to let you know, that's a tribalism alert.
The thing that's making him unpopular is all these fire training that he's done. He doesn't mind that because it takes 2 seconds. Completely useless, but and done in 3 places.
All right, well, that seems a nice segue. Just to let you know, from the survey, people were about equally split about this, and I guess a lot of people wanted more information about context to know what would that involve, and maybe we didn't mind if he was doing some damage control surgery, but we did mind if he was doing spinal surgery. So context, I guess, is important. But what about this then practical thing? Because there is a lot of paperwork if you work in more than one place, and he will end up doing fire training in 3 places. Can't there be some kind of cross-recognition? I'm looking at Vincent and Susan here.
I think definitely, but it relies on the organisations obviously understanding what each of their requirements are. I guess it's a similar concept to regional accreditation. Why should you have to seek present your documentation to every service you go to in the area? Why can't there be a centralised way of doing that? In fact, there is.
Yep.
I mean, fire training is fire training. You get it on the plane when you start. Every time you get on the plane, we got it in this room this morning about there's the exit, run for your life sort of stuff. So, I mean, you're going to get fire training everywhere. But I think in terms of the measurement of performance and the management of people's own performance, there is a role that, thinking to the future and just thinking about IEMR and the digitisation of all of the data and stuff that we've got, there must be scope in the future for people to have a portfolio of their practice that is able to be demonstrated to each of their employers that would tick off a lot of that work, with employers contributing to that, whether they're public or the private sector.
Yeah. So again, Ollie, this is probably something you were talking about yesterday. So there are, of course, professional bodies and others that track things like surgical outcomes. I'm aware of those. But this is your whole point about, for instance, the Pap smear EPA, and it has an expiry date. You'd have this, and have people actually done this, got portfolios via EPA type things?
No, it's really not. It's really a little too early to have experience about that. The whole concept of EPAs is only got traction about 5 years now. So we'll have to look at those, and it was focused on training really. So within a training period, but I think it resonates with many people. And many clinicians that I talk with, experienced people that would say, I don't do this procedure very often enough. I would actually find it logical not to be accredited to still do that. So I think it is something that could happen in the near future.
So it would make some intuitive sense for most moderately self-aware clinicians, I think you're saying. Yeah. Just as out of interest for the comments on the last one, again, Vincent sort of talked about that. Why does it seem much easier? There were a lot of things along the lines of less bureaucracy, more autonomy, but there are a significant number of responses saying it was easy to hide, and that was the word used in 3 different responses in private. Any comments on that?
I would agree with that. I think that that's always the challenge. How do you know? I mean, you have to understand that people want to come and work in the private sector for a whole range of reasons. I would be concerned about anyone who wanted to work exclusively in the private sector, to be honest. That's what I was alluding to before. Obviously, it doesn't mean if you are that you're a bad doctor, but I think that is the challenge, to try and find those who try and sort of understand. There might be some who are trying to hide, and I don't think we have any, other than implementation of some of the strategies that I sort of elaborated on. There's no easy way of doing it. We do rely a lot on smoke. What I mean by that is, if you hear something about a particular individual from one person, you tend to not think about it very much. But if you're hearing it from 6 or 7 different people and the nursing staff, you've got a problem.
Along the lines of the multi-source feedback, yeah. So we're going to move on just to consider this second one as the last one, and then we'll just have 5 or 10 minutes for discussion. So again, situate ourselves in a different professional group, obviously one a little bit closer to my own world. Here's an emergency physician, sort of mid-career you would say, who's been very competent in the context in which she's worked, which is a regional ED. She's done a balance of education and clinical work. But let's face it, there are some high-end procedures that she hasn't done very much, partly because the trainees are very good, and there's some newer skills around since she finished her training that it just hasn't seemed necessary for her to become proficient at. There's no doubt she's done everything her college has required her to do to maintain her CPD, but now she's moving to a different context. She's suddenly going to apply to a job in a big trauma centre, where probably the skill sets required are going to be quite different. So once again, we're thinking, how do we assess the scope of practice? What boxes do we put around this? How would we know if Anne-Marie was still competent, i.e., and then competent to do the job? And should she be telling her employer, look, I really can't work in the resus room of this big trauma centre, should I work somewhere else? And have we got measures that would be sensitive enough to pick up if she were struggling or not managing? So again, I'm going to go to you, Susan. She's pretty open about this. Is she going to be good enough?
Yeah, well, that's good. Well, I mean, hopefully we've gone through a merit-based selection process and articulated the requirements of the job, so we're not going into this with our eyes closed about her scope of practice. And perhaps we've recruited her because she has particular skills in education and as a supervisor that we also want to bring into our department. But with an acknowledgement of a deficiency in new skills and intubation and that which are key to working in a trauma centre, I would expect that there would be an upskilling program put together for her. And that might be a 3-month program to start with, done by the director or deputy director in the department, supervised, and it might even use things like simulation training to go back and do a bit of that, and then running some emergency teams and that. And it may be that, depending on the numbers on shifts, she doesn't do a shift by herself as the consultant for a period of time, or the overnight on call until that 3-month period of upskilling is in place and she's happy and the department's happy that she's got the skills in place.
So you'd sort of rely on her thoughts and the director's advice as to what that program would be?
Yes.
Yeah, okay.
Yeah, we'd expect the craft group to advise us about the
Yeah,
expertise.
okay. And just to clarify, I think what Susan just
Yeah.
said then was a simulation service is absolutely essential for a hospital. Yeah. Okay,
Not
sorry,
to
Julian.
upset anybody.
That's right, yes. So, but again, I'm going to go back to you, Ollie, here. This is really central to this idea of, let's say, your EPA being in context. Can you sort of talk about that in the context of this one? Because she's kind of got this EPA for working in critical care, but just not quite the EPA for working in this context. How would EPAs deal with this?
Yes, I think it's a really nice example. So there's distinction between whether people are finishing training with competencies that they don't use, or that they are confronted with a new situation, that there's new things that they have to acquire. I don't actually like the connotation, the word of deficiency so much, because it gives a sense of shame that you're not meeting standards that you should meet. But instead, you should think of the reflection of your portfolio of EPAs that you can do as the natural way of working, and realizing that during your working life you must learn new things. It's logical. It's actually unacceptable if you don't do that. But if you have been working I think she worked part-time for a while and she didn't use those skills, it's very natural that she would lose our trust to do that unsupervised, as I use in the terminology of EPAs. So it should not be something shameful, but rather something very rational. You go to another place and you actually do that. We see that a lot with our training of physician assistants, what I showed one slide of. They're very much trained in a focused area of what they do. But since they have a bachelor diploma of physician assistant, when they move to another place, they definitely have to retrain new things. It's not a shame at all. And it usually takes shorter time than a full training.
Yeah.
You could probably do that rather quickly if you're just a normally functioning person.
Yes. So that, of course, depends on if you can actually define what these things are. And I saw Susan smiling over there. It also depends on this person actually recognising that deficiency in themselves. And maybe both Graham and Susan might like to comment that, us emergency physicians, we like to think we can still handle it. She might not recognise that she should be restricting her scope, at least temporarily.
Yeah, you'd have to deal with that if that was an issue, but I think that's actually less likely. And what I commonly see more is people who actually have the skills and they just need a bit of assistance and supervision or coaching, which is exactly what Susan was saying, and I think it'll solve the problem. It'd be the same if she worked in the tertiary centre and went out to the other place. She'd have to pick up her paediatric skills or some other skills that she wouldn't have practiced for 20 years or whatever. So, we all do that when we move locations of practice, because our scope of practice changes.
It's not that well reflected in our CPD though, is it?
No, it's not.
So it does rely on us having an individual insight rather than our college having a little block that we're competent at or not. Do you see that changing?
We've got our expert in CPD for the college in the room, Kathy, but I expect the new changes to CPD to much more closely align our CPD with our scope of practice. I think there's been a deficiency in our CPD program, and to make sure that they are aligned better based on some learning goals and some outcomes is where I think we need to take our CPD programs.
All right, I'm going to ask for some questions for the audience soon, so feel free to go up to the microphones if you think that. While we're thinking about that, Ollie, this all sounds well and good, but you've got to have the right assessment tool then if you're going to have these little more micro blocks of competence or EPAs. What sort of tools, and is that really feasible?
That depends a lot, of course, on what activity you're talking about, but observation would be important. Direct observation of the skill, if it's really a skill that's very specific, you'd have to just see people do that. If it's more in the realm of professionalism, you might have to rely on multi-source feedback types of information. There could also be, sometimes it could be knowledge, very specific knowledge that people would, and you could even think of having people do a test. It could be kind of a simple way of with e-learning or e-test, just to make sure that people have that knowledge that you think is required for that procedure.
Well, there probably is some logic to Americans doing their board exams. Andrew Padmos.
Thank you. Andrew Padmas from the Royal College in Canada. It's been about 10 years since I've been actively part of a clinical operation since I moved to the college, but there's missing persons in this conversation in our context, and that would be the division head and the department head. Neither of these individuals in this setting would probably be hired into one of our divisions or departments unless they were able to show before they took up the post that they had corrected a deficiency, and they probably wouldn't be looked at unless they had some surprising quality or special skill that was in demand. We would have lots of young people with a full scope and full enthusiasm to take on these jobs. What is the role of the department head or the division head, or can your individuals walk in and say, la-di-la, I'd like to do this, but I won't do that?
So what you're saying is, how does recruitment kind of fit into this thing, and do we just exclude people who haven't got those skills? I don't know, Susan, you might want to take that one.
I suppose that was my point, that we would have gone through an open merit-based selection process and presumably went to the recruitment of this individual with our eyes wide open. That's why I intimated perhaps she does have particular skills in education and supervision that we really want to attract into the department, because departments are made up of many folk who each bring a different skill set, and sometimes you want to fill that particular skill set. So yes, I was going to say too, the reason why we would take on people who then needed upskilling is that in the public sector we're fortunate enough to have the resources to do it, and of course people have generous professional development leave allowances as well, and leave balances that allows them to happen once they're employed.
Sorry, yeah, go for it, Vincent.
I mean, I think that's a really interesting point. I mean, how I think I think the biggest problem is when you, as we talked about before, when you're going from perhaps a tertiary centre to a much smaller rural centre. Now, I'm the director of the emergency department in my hospital, and we struggle to attract really good quality emergency physicians because they don't want to come out and work in the even though we're only an hour away from Melbourne, we're within easy access. Great lifestyle. Is anyone here who wants to come?
If I get sacked from this job,
and I can say we'll probably overlook some of the deficiencies in your training.
Yeah. So there is So I think to answer your question, there's certainly a supply and demand issue.
It is supply and demand.
Yeah.
Hi, Martin Richardson, orthopaedic surgeon from Victoria. Just a little bit concerned about the negativity from the panel about training in the private sector. I left the public sector when it became unethical to practice an orthopaedic surgeon. We had no access to in-hours trauma lists. We lost all of our ability to do audits and that sort of thing. And now I work in the biggest hospital in our state, probably in the country, where we do have very good training. We do come in for every case with our registrar. That probably doesn't happen in other situations around the place. I'm just a little bit concerned about the negativity of the potential of the private sector to be able to train our trainees, our medical students, etc. We have our own clinical school. The second part also is we haven't heard anything about the military. When I did leave the public system, I actually wanted to continue my public giving back, joined the ADF, and the ADF certainly provided me with my first 360-degree multi-source feedback, which wasn't offered to me in the public sector, and we haven't talked about the military at all as part of the training. Thank you.
Yeah, and I'm not sure if we have sufficient expertise to do that.
Can I just say something about the training in the private sector? That's a really good point. I haven't spoken about it today so much, but I can tell you now that it is an amazing resource, an opportunity for training that often goes missing, often goes unfulfilled. So when you think of the volume of work that's done and the quality of the work that's done, I think certainly our hospital has orthopaedic registrars. We have a medical registrar. We're a not-for-profit hospital. We have interns. We have part of an intern training program, and they are loving their experience with us because access to patients is far greater than they feel they've perceived.
And this is common in pathologists, radiologists across a range of specialties.
I just didn't think any of us made any comments about training in the private sector, certainly no negative ones, Martin. So rest reassured, and Martin runs a really good orthopaedic training in private, probably one of the best training examples of private sector surgical training in the country, in my opinion.
I would just say it is very well supported too in Queensland. There's a lot of training that goes on in the private, and certainly the Commonwealth Specialist Training Program, which has allowed that to happen through resourcing it, has certainly expanded all of those positions.
Yeah. Kevin.
Good. Kevin Emery, President of the Canadian College. I just wanted to very briefly pick up on Graham's point and just say that From our perspective, we absolutely do not think that bullying and harassment is something specific to the Australian context or to RACS. We actually feel we very much have the same issue in Canada. We were actually very impressed by RACS's response to this. If there's any difference in our context, it appears to be a little bit less in terms of perhaps some of the extremes of sexual harassment and physical violence, but there is no question that we have a similar problem in terms of bullying, harassment, and discriminatory behavior. Our council has taken this extremely seriously. Our structure is such that we're a little bit different. We're not the providers of education, but accreditors, but we feel very strongly that that's not an excuse and that we can't simply stand back and say, well, that's not our problem, it's the problems of the programs and the faculties. So we would certainly strongly support your sense that this is a shared problem that we have across disciplines and across countries.
Well, Tony Jones-like, I'm going to take that as a comment. Another question.
Thanks, Victoria. David Morgan, I'm an orthopaedic surgeon also from Queensland.
Do
And
we
I'd
think
like
we've hit a
to
nerve?
express a bit of concern about the response from the panel about the first scenario. Not alarm yet, but a little concern. First of all, the orthopaedic surgeon, this second year consultant who specialises in knees, was trained by the Orthopaedic Association in Australia and is therefore trained to an exceedingly high level in all facets of orthopaedic surgery, and importantly also possesses insight. Now that surgeon would have the ability to decide whether or not he could actually handle this complex pelvic fracture after hours or not, but would also have the skills to be able to behave in an appropriate emergency fashion for that patient in a life-saving way and be collaborative with colleagues such as vascular surgeons, urology surgeons, and more importantly, would also have a good relationship with his other colleagues on the staff who may be experts in pelvic surgery fracture. So that second year consultant who is a knee surgeon is definitely capable of fulfilling those duties for all of those good reasons. The second thing is that he is absolutely entitled to be a subspecialist in knee surgery and is absolutely entitled to be that subspecialist in the private sector should he so wish. And in fact, that is exactly the way the modus is turning in our country now. And it has been for a decade or so. And to suspect that he may be there to hide his deficiencies in the private sector from public scrutiny is a serious accusation and does require some evidence. Thanks.
To answer your question, there were merely responses. And I think it's nice to hear. We've heard already about one Nirvana up there at Metro South. Now there's another one in the Australian Orthopaedic Association. But I think there was a really important point in what you said, and that is that the breadth of these competencies, and that's again what Ollie said, you have to be entrusted in something that covers a breadth of competencies, and that insight is one of them. All right, okay, two more, these two.
Philip and Bobby Brief, a paediatrician. I just want to approach bullying from another direction which hasn't been discussed, which is the increasing online digital bullying of us by disaffected patients and unverifiable sites like MD Rate emanating from America. People purport to comment on us, and it's generally the disaffected patients, people with an axe to grind and others who are publishing the most atrocious defamatory material about us, which apparently we have no recourse to unless you can find a software firm that can alter the Google search criteria so your name is now down number 27, not number 2. I wonder if the panel wants to comment on the bullying that we're experiencing.
Yeah, it's a bit out of scope, but I'll let Susan give a short answer.
I just comment on that. We just, in November last year, launched a My Health, a Doctor's Health and Wellbeing survey, and included particularly questions about bullying and harassment. And the largest cohort that was bullying and harassing doctors was patients and their carers. Of everybody in there. So it has surfaced as an issue for us, of course, in the workplace, and we've seen that before. And we're just grappling now with how to deal with that. How do we do something about that for them in the workplace? Yeah.
Last question.
Stephen Dean, Surgery, University of Newcastle. We've heard a deal this morning about training and supervision and feedback and so on. In many aspects of society and business leadership, we're hearing about coaching. Can I ask the panel to comment, is coaching different? And if so, what attention are our colleges giving to coaching, both within training and the training pathways and in continuing professional practice?
So in the last 30 seconds, if we can just take a massive topic like actually giving feedback, but yes, go for it.
So there's the three words. There's the mentoring that people talk about, coaching. I struggle with the differences, to be honest. I'm only a surgeon. but I struggle with the differences between those. And then there's supervision, which implies some assessment. And the truth is we probably do all of those roles from time to time, but what we have to be quite clear when we're coaching for improvement. I think someone used, it might have been Ollie yesterday, used some word. He said, well, you're either trying to improve someone or you're trying to get rid of them. And you've got to decide which you're doing. So I think that's the problem, is the blurring of the roles. I've quoted you not very accurately, Ollie, I think.
I just say we do a bit of coaching, and as I said, coaching leadership styles tend to be more effective with medical staff in particular. And it's my experience that clinical directors and that when they come to you with problems and that, they're looking for coaching or a strategy about how to deal with it. They don't necessarily want you to come in and solve their problems for you. They want you to give them some way of approaching it from themselves, and I consider that coaching for them.
Good point. All right, well, on that note, we better have some lunch, but can you please join me in thanking our panel?